Hello everyone. Today we want to talk about the neurobiology of mental illness. This is being recorded as a video resource primarily for the students of my class in Psych 2003 Physiological Psychology, but I hope it might be a useful resource to many others. Now, one of the things we've been saying repeatedly inside of this course, Physiological Psychology, which is also can be considered behavioral neuroscience, is the fact that many people consider that all aspects of human behavior come directly from changes that take place in the brain. So my students will know that we've said things such as your emotions, love, fear, anger, things such as your affections, how you relate to other people. All of these things are believed to be due to changes that are taking place in the brain. So now when we consider mental illness, it will be no different. We want to look at mental illness from the point of view of what are the changes that are taking place in the brain. And this becomes particularly important in this context because if we can understand those changes, we can perhaps both prevent mental disorders and also more effectively treat them. We begin our class today by just basically reviewing some facts about mental disorders. And one of the things that might not be well known is the fact that mental disorders are very, very prevalent across the earth. We're not going to look at it in detail, but you can see that there are many parts of the earth where mental disorders affect up to 25% of the population. And those parts of the earth that don't report such figures, often this is because of under-reporting. So when we talk about mental health disorders or mental health, we're talking about something that affects many people, but it's often not talked about. One of the measures that the World Health Organization came up with to try to help us understand the burden that a disease has on a population is something called the DALY. Now, the DALY stands for the Disability Adjusted Life Years, as you can see at the bottom of this slide. And it's made up of two components, the years lived with the disability and the years of life lost. So let's imagine someone contracts, or let's imagine someone develops diabetes when they're about 55. And let's imagine the average life expectancy for that person in that country is 70. And suppose the person has diabetes, doesn't manage it very well, and then passes away at 65 due to complications from diabetes. That person would have lived with the disability for 10 years and would have lost 5 years of life because of the disability. So the overall daily or disease burden would have been 10 plus 5, which in this case is 15. Now let's imagine somebody develops depression at about age 20 and then lives the next 45 years of their life with depression off and on and dies at age 65, but not due to depression. In this case, there were no years lost due to the disease, but they lived 45 years with the disease. And so their daily would be 45. And using these measures, you can see why mental health disorders are considered such a burden on society. And then if we just look at some hard numbers, almost 500 million people across the world suffer from mental health disorders. And using the daily, they represent up to 15% of the disease burden that surpasses both cardiovascular disease and cancer. So this is a graphic that allows you to look at some of the issues faced by persons suffering with mental health and also the numbers. And also if you look in the top right-hand corner, the fact that many of them suffer disadvantage and discrimination. So that's something to remember when we're considering mental health disorders, because that's one reason we might be surprised at these figures, and it's something that affects people and makes them not willing to seek treatment. In a study done in the Caribbean, this was a study done by myself and another group, we looked at the attitudes towards several mental health disorders. We compared them with a positive control, someone who was considered religious, in this case a Christian, and a negative control, a criminal. And what we found is that persons who had mental health disorders were best viewed in a neutral way or in a very negative way, as you can see by the recovering alcoholic here, suicide and depression, schizophrenia, and heroin. Somebody who suffered with diabetes was seen very, very positively, scoring almost maximum. And these are not just figures that come out of the Caribbean. In the UK, 70% of people affected with mental illness talk about some level of discrimination. And sometimes, depending on the disorder, unemployment rates can be as high as 90%. So the issue of stigma is something to be aware of. And it could be a reinforcing concept in mental health disorders. Now here's another interesting fact about mental health disorders. Some studies have shown that if you look at the wealth disparity and equality in different nations of the earth, that is the ratio of the top 20% earners versus the bottom 20% earners, and you plot it against mental health prevalence, you can see as wealth disparity increases, so does mental health disorders. Now this makes us wonder, is there a societal cause to mental health? Is that one of the environmental factors that's promoting mental health in certain societies? And this leads me on to another interesting consideration as like a bunny trail of this particular topic. And that's the issue of the social brain. The social brain. Now, adult human brain weigh about 2% of the body weight, but they consume about 20% of total energy. The question is why? Why does a fetus have such a large brain that then makes it difficult to have the baby, as many mothers will know? People have tried to come up with many answers for the reasons why we have this big head relative to the body. And some people have said it's because we need a big brain to control our body. Some have said it's to solve complex problems. But some people have argued it's to interface and meet the demands of complex social systems. So if we look at this particular graph here, this is an interesting study. This study looked at groups of non-human primates and the size of the groups, and then looked at the relative size of their neocortex. And what they found was the size of the neocortex increased relative to the rest of the brain as the group size increased. Now, if you remember, the neocortex is the newest part of the brain, and it's that part of the brain that has all the folds, the sulci and the gyri. In other words, the larger the group size, the larger the neocortex relative to the rest of the brain, suggesting that the neocortex may have been developing to help animals and to help these primates deal with complex social relationships. Now, if you model that, if you extend that graph and plot what that would be for humans, it comes up to about 150, meaning humans should cluster in sizes of about 150. And based upon the person who did some of this work, Robin Dunbar, that number is now known as Dunbar's number. And follow-up work was done, and it looked at how humans have clustered throughout history. And you can see examples there: modern armies, companies, certain societies, churches. All of these tend to operate around 100 to 200, somewhere around that 150 number. A more modern example is Facebook. Some work has suggested that the average number of friends on Facebook is about 120 or 150. But then we know that there are many, many people with a lot more friends. Well, Dunbar carried out some work on this, and based upon his work looking at 3,000 people, he established that even using Facebook, people can only maintain relationship with 5 in their closest support network. They have a further 15, a little bit wider, is a sympathy group who they can confide with. And then they might have about 50 close friends. After that, we move into casual friends, acquaintances, and the ability to recognize faces at 1,500. Now, there is some individual variability dependent on personality and other factors. But it's very, very interesting to see how this spectrum links to the idea of the social brain. Okay, we're about to look at 2 mental health conditions. But before we do that, I want to encourage you to look at a TED Talk by Tom Insel, who talks about rethinking our approach to mental illness and argues for the fact that we should consider mental disorders, not behavioral disorders, but brain disorders. It's worthwhile looking at that before you consider listening to the rest of this lecture. Tom Insel, and you can find that for my students on your course page, and for others, you can find it on YouTube. So, how do we define mental health illnesses? Well, usually that's done by manuals put out by the American Psychiatric Association and the equivalent body in Europe. And one of the challenges we have here is those manuals, in many cases, don't have diagnostic tests for mental health disorder. And so we have to define them based on symptoms. And then not only do they look at the symptoms, but they focus on whether those symptoms are causing distress, disability, or increased risk of death, pain, disability, or loss of freedom. Collectively, that allows us to understand and define mental health disorders. But unfortunately, that's not the best way to do that because one, it's quite complex, and two, it doesn't give us definitive markers. So let me give you an example. If someone presents with chest pain, that could be because of a heart condition. It could be because of a heart attack, or it could be because of cardiomyopathy. But it could also be because of a gastrointestinal condition like acid reflux. It could be because of a muscular condition, a muscle strain. It could be as a result of a respiratory condition because something's going wrong in the lungs. The symptom chest pain could have many underlying causes. And that's the challenge that mental health scientists face when they use symptomatology to make their diagnosis. Unfortunately, despite all the advances, we don't have many or any useful diagnostic tests for most mental health disorders. So in that case, symptoms become very important. And in thinking about defining a mental health disorder based upon symptoms, we have to think about several things. Is it just one symptom or is it many? So let's consider depression and the fact that somebody is feeling sad. Just knowing that they're sad is not enough. But if they're sad and they have other symptoms like loss of pleasure and sleeplessness, that adds to the case of a mental health condition. Then you have to consider duration. Is the duration 2 days, 3 days, or is it 2 months or 3 months? That will then impact upon the diagnosis. What about severity? Is it just a little bit? You're just feeling a little bit down? Or is it so severe that it's now affecting your functioning? You're not going out to work or to school, as we were just talking about. And that leads on, of course, to what's the impairment caused by these symptoms. And finally, have we been able to exclude any physical factors that might be the predisposing cause to these symptoms? So let's look at a condition, schizophrenia. Now, there are many myths about schizophrenia, and there's a lot of misunderstanding about what it is. Many people think it's multiple personality disorder, and that's not the case. So what is schizophrenia? Well, schizophrenia is a chronic and severe mental disorder. It affects how the person thinks and behaves. They seem to lose touch with reality. And as a result, they're experiencing things that aren't actually happening. In addition, they end up having trouble with thinking and other behavioral deficits. You can see by looking at this graph that schizophrenia tends to peak, its peak onset tends to be in late adolescence and early 20s. This is particularly so for males, with it being a little later for females. The incidence approaches about 1% of the general population. So that means about 1 in every 100 persons suffers with schizophrenia. And it tends to be a chronic disorder. These are just some figures from the US, which again would tell you something that you might not be aware, that schizophrenia incidence or prevalence, far outweighs things like Alzheimer's disease and diabetes. Again, suggesting that there's a hidden illness in our society that very often we're not aware of or we ignore. What about genetic linkages? Now, genetic linkages are important because genetic linkages help us to understand whether something has a biological origin or whether it has a environmental origin. In this slide here, now to diagnose schizophrenia, again, we use the Diagnostic and Statistical Manual. And basically, the definition of schizophrenia is you must have 2 or more of the following for a significant portion of time during a 1-month period. And at least one of these must be delusions, hallucinations, or disorganized speech. Those are considered the positive symptoms of schizophrenia. Now we're going to look at the different symptoms in schizophrenia. Schizophrenia can be broadly classified into 3 categories of symptoms. 3 categories of symptoms. Positive symptoms are hallucinations and delusions. That's something being added on to the person's experience. Negative symptoms are characteristics of the individual that are absent but should be present. And then cognitive symptoms relate to how they process information. So let's look at positive symptoms in a little bit more detail. And we're going to focus on 3 sets of symptoms: hallucinations, delusions, and disorganized thinking. Well, what are hallucinations? Hallucinations are false sensory experiences. You're hearing voices or you're seeing things. Examples are audible thoughts, where the patients can actually hear their own thoughts, or they hear voices arguing or commenting upon their behavior. Very often they tend to be auditory, but they can be from the other senses. Now, interestingly, a study was done on a group of persons suffering with schizophrenia who were actively having auditory hallucinations. And when they were placed in an fMRI scanner, it found that the area responsible for processing sound and language was showing activity, as you can see here. What this tells us then is that for the person suffering with schizophrenia, this is not something they're imagining, but this is something that's happening at a brain level. Now, this hasn't been shown in all persons with schizophrenia, but we could definitely say for a subset, this is not just something they're imagining, but something is happening at a neurobiological level to cause these hallucinations. Well, what about delusions? Delusions are fixed false beliefs that run contrary to all the evidence. And you can have delusions of persecution, of grandeur. You can have the delusion that people are putting thoughts in your mind or broadcasting your thoughts. And this is very often a major feature of a psychotic episode associated with schizophrenia, and very, very destabilizing for the person themselves and also for their social contacts, their family and friends. And finally, disorganized thoughts, which is often connected with how they speak. So their speech is disorganized and fragmented, and they make associations in a very strange and abstract way, and they sometimes can make up new words. This is an old text written by somebody describing his experience with schizophrenia. He said, "My thoughts get all jumbled up. I start thinking or talking about something, but I never get there. Instead, I wander off in the wrong direction and get caught up with all sorts of different things that may be connected with things I want to say, but in a way I can't explain. People listening to me get more lost than I do. My trouble is that I've got too many thoughts." You might think about something, let's say that ashtray, and just think, oh yes, that's for putting my cigarette in. But I would think of it, and then I would think of a dozen different things connected with it at the same time. So disorganized thoughts manifested as disorganized speech and loose associations is a major feature of schizophrenia many times. So those are our positive symptoms, things that are added that shouldn't be there. Now, what about negative symptoms? Well, negative symptoms are characteristics that should be present, but they're now absent. And they often endure beyond the acute psychotic episode and are often more difficult to treat. So somebody can have an acute psychotic episode with hallucinations and delusions. And often those can be treated, but it's much more difficult to treat the negative symptoms. So what are some negative symptoms? Well, flat affect. The emotional response to different situations is the same. They don't have strong emotions, as you can see in the image on your right. They lose interest in usual routines of life, including taking care of themselves, grooming and hygiene. In this case, they might stop speaking or have very simple speech. And they also can lose the ability to experience pleasure from friendships. And all of this might lead to withdrawal from social contact. And that's something to be aware of and something that we don't want to happen because it doesn't help the situation. And then finally, cognitive symptoms. Difficulty paying attention, difficulty focusing. They are now shown that there's there are issues with working memory and issues with making decisions and processing information. This is something that had not been spoken about prior, but has now gained a lot more attention. Now, the picture you see on the right is supposedly a set of pictures done by an artist who had developed schizophrenia. And some people have argued that the images of the cat were at different stages of the disorder. But there's now a lot of people who say that's not true and really doesn't represent the progression of the disorder. It's just a useful picture for us to capture and to remind ourselves that cognitive symptoms are now being considered a very significant part of persons with schizophrenia. Now, I mentioned before that the idea of a diagnostic test is very important. And this is just some newer research that suggests that eye movement might be something that can be used in the future to determine if someone has schizophrenia or not. And so you can set up an experiment where you allow somebody to track an image on a screen and you look at the eyes. And what they've shown is that persons with schizophrenia have difficulty with what's called smooth pursuit. You can see here at the bottom, the person without schizophrenia makes a very smooth following of an image on a screen. But the person with schizophrenia, it's a lot more jagged. And they have the ability to smoothly move over free viewing of photograph. They focus on a narrower area as compared to a person without schizophrenia. And you can see even when they're fixing on a single point, the person without schizophrenia can do that. The person with schizophrenia is unable to do that. And there was a model that was developed that said they were able to detect schizophrenia with about 96% accuracy. And these are the kinds of things that people are trying to do to help come up with a diagnostic test for schizophrenia. Why this will be the case, people are investigating.
Catatonia. Catatonia is a state of increased muscle tone at rest, which is abolished by voluntary activities and therefore distinguished from extrapyramidal side effects. In these clips you'll see a variety of forms of catatonia demonstrated by a role player being examined by a psychiatrist. This clip shows force grasping, where a patient is unable to comply with instructions to resist a preferred handshake. Characteristically, the interviewer has difficulty getting his hand away.
Move your arms around a little bit, is that okay?
Mm-hmm.
Okay. Okay, just leave go. Just relax a second. What I'm going to do, I'm going to put my hand out, but I don't want you to shake it. Okay, leave go. Think carefully about what I'm asking you to do. When I put my hand out, as though I'm going to shake your hand, Don't take it. I do not want you to shake my hand this time. Okay. Okay, that's fine. Just try and relax for a second.
In this clip, waxy flexibility is demonstrated when a patient's limbs are placed in an unusual position, where they remain for a sustained period.
I'm just going to move your arms gently. Okay. You said that you feel that there's something not quite right. You're having some difficulty explaining that.
The patient in this clip is displaying opposition, resisting all attempts by the examining doctor to move his arm.
I'm just going to move your arm gently. Just let it come with me. Okay? Okay, that's fine. That's fine. I'll try and pop it down this way now. Okay. Okay, that's fine.
A more intense form of opposition is negativism, where the patient actively resists all attempts to make contact and also, in this clip, displays aversion by turning away from the examining doctor.
I'd like you to just shake my hand. Okay. And shake my hand, Peter. Okay, we'll leave that for now.
Okay, so let's look about some of the theories of what's going on from a biological perspective in schizophrenia. Well, we first of all want to talk about something called the dopamine hypothesis of schizophrenia. Now, the earliest drugs used to treat schizophrenia emerged in the 1960s, and they were known as typical antipsychotics. Examples are chlorpromazine and haloperidol. Now, these drugs block D2, dopamine receptors, and they were found to be very useful in treating the positive symptoms of schizophrenia. Then it should be reminded that drugs that release large amounts of dopamine, like cocaine and amphetamines, these are street drugs or illegal drugs, they can induce psychotic states that are very, very similar to schizophrenia. So based upon this, people came to the conclusion that maybe the underlying problem in schizophrenia was there was too much dopamine. So drugs that promoted increases in dopamine would lead to schizophrenia, and drugs that block the D2 receptors could then help alleviate schizophrenia. Based upon this, there have been many years of research looking at dopamine, and there have been mixed results. Some patients do show higher levels of dopamine in the cerebrospinal fluid. Some patients at post-mortem show increased dopamine receptor density. But let me just emphasize here, this has never been all the patients that have demonstrated these things. And so the general theory that has been put forward to explain schizophrenia is that there's overactivity of dopamine in the mesolimbic pathway, and that leads to the positive symptoms of schizophrenia. Now, the mesolimbic pathway, if you remember your studies on reward and behavior, are important for the reinforcement of behavior. And so some people have suggested that you can have an irrational thought, and most people brush it away. But if your mesolimbic system was particularly active when that thought occurred, you might then have that thought being reinforced, and that can lead to a delusion. And that has been one theory that's been put forward to explain the beginnings of schizophrenia. One piece of evidence that supports that is persons with schizophrenia often report euphoria and that sense of pleasure and a high when they now develop their positive symptoms. However, the dopamine hypothesis has many challenges. one of the issues is that many patients given these antipsychotics did not show improvement. In some cases, up to 70% of patients did not show improvement. The second thing was the time course of action. Even though the drugs blocked the dopamine receptors straight away, the improvement in symptoms did not take place straight away. So that means something else seems to be going on. Thirdly, most typical antipsychotics had very little effect on the negative or the cognitive symptoms of schizophrenia, again suggesting that dopamine was not the underlying problem. And there are other things that have come up in more recent years. The fact that newer antipsychotics affect D2 receptors less and can affect D4 receptors and other neurotransmitter systems like serotonin. And then there are other drugs that increase dopamine levels, that do not increase dopamine levels, but can cause psychosis. And we'll talk about that in a little while. So all of that has led people to say that clearly dopamine might have a role to play, but it's not doesn't seem to be the underlying insult or problem in schizophrenia. Today, people often talk about what's called the glutamate hypothesis of schizophrenia. Now, this emerged from work with the drug phenylcyclidine, PCP, or angel dust. Now, this drug blocks the NMDA receptor. And when it does that, there's no increase in dopamine, but persons then report positive symptoms, negative symptoms, and cognitive symptoms of schizophrenia. So here's a situation where you're blocking a particular receptor and you're getting all the symptoms of schizophrenia. And this has led to the theory of hypofrontality. And that's the fact that people suggest that the core problem in schizophrenia is reduced glutamate in the frontal lobes of persons with schizophrenia. And that reduced glutamate then can affect the levels of dopamine in the midbrain, in the mesolimbic system. And that reduced glutamate is probably responsible for the negative symptoms and the cognitive symptoms. And then it leads to an increased dopamine, which is responsible for the positive symptoms. And that's why antipsychotics work on the positive symptoms, but they're not able to alleviate the low levels of glutamate in the frontal lobe. And that's the hypofrontality hypothesis, which is gaining a lot of traction at the moment. Finally, let me just mention the developmental hypothesis of schizophrenia. As we said earlier, schizophrenia often presents in late teen years, early 20s. But often when they go back and they check the records, they found that somebody who has schizophrenia that presents and is diagnosed at, say, 21, if they look in their past, they might find that the child displayed abnormal behavior a lot earlier. They did not have good social adjustment. There were developmental delays. There was pre-morbid psychopathology like conduct disorder, anxiety. All of this suggesting that something might have gone wrong earlier for this child and this young person, but it wasn't realized that it was a schizophrenia that was developing. And studies have now shown that the rate of gray matter loss in persons with schizophrenia during teenage years and throughout life is actually a lot higher. And the issue here might be that as gray matter loss increases, symptoms might not initially appear, but as it keeps getting more and more and more, eventually it crosses a threshold, and now the person presents with schizophrenia. So again, this is something that people are trying to understand. The other thing people think about is there a trigger, maybe in adolescence, that leads to a sudden increase in a loss of gray mass that leads one to develop schizophrenia? So this has led to the idea of a gene-environment interaction, or the vulnerability hypothesis, that there must be some threshold of causal forces that must be exceeded to cause the illness, that a person can have a genetic vulnerability, and then a set of environmental forces act upon that environment, upon that vulnerability, and leads to schizophrenia. What are some of the vulnerabilities? Well, could something have happened during childbirth or in the fetus? And we do know there are studies that have shown that kids that were conceived in winter months have higher levels of schizophrenia than others, and that has been suggested to be due to increased viral illnesses. Or what about some kind of stress that took place in adolescence that acts upon these genetic vulnerabilities and leads to the increased risk of schizophrenia? And so this is just a graph showing you how in Northern Hemisphere, seasonal birth effects on schizophrenia. As I said, people born in early spring are more likely to develop schizophrenia, perhaps because the mom was exposed to colds and flu the winter before, during the child's development in utero. And finally, just a couple things to note, that there are anatomical changes in persons with schizophrenia. Certain parts of the brain are smaller, such as the entorhinal cortex, the cingulate cortex, the hippocampus. And because of that, you find that the ventricles are larger. And this is something that increases as schizophrenia progresses. And when you look specifically at the hippocampus, you see that there's disorganization of the neurons, suggesting beyond the neurotransmitter changes that are occurring in schizophrenia, something more fundamental is going on with the processing and the organization of the brain matter. So that was schizophrenia. We saw that there were three main hypotheses behind it. The model that is no longer, well, it's still considered, but is not widely accepted, the dopamine hypothesis, the glutamate hypothesis, and the neurodevelopment hypothesis, which links to the whole idea of having a genetic vulnerability that's acted on by the environment. Let's talk now about depression. So depression is part of a wider group of disorders, and we're not going to look at those disorders. We're going to focus on depression, but that wider group of disorders is called mood disorders. Now, mood is to emotion what climate is to weather. Climate reflects long-term trends. So you could be in the dry season here in the Caribbean, but it could be a rainy day. If you were asked to describe the weather on that day, you would say it's raining. But if you were asked to describe what season are you in, well, then you'd say you're in the dry season. In the same way, mood refers to the pervasive emotional state over a long period of time that's influencing the person. So somebody could have a depressed mood, but that doesn't mean they won't laugh at a joke or have a particular day where they're not feeling that depressed and feeling generally happy. Depression is considered to be one of the leading causes of disability worldwide, using the daily metric that I mentioned to you. Its onset is also in late teens and early 20s, but in this case, women tend to have a higher incidence than men, often in the ratio of 2 to 1. Again, you can look at the DSM to discover the symptomatology that defines depression or major depressive episode. It's a period of at least 2 weeks during which there's depressed mood or loss of pleasure in nearly all activities. And during that time, they should also experience 4 of these symptoms: a change in appetite, sleep, or psychomotor activity, decreased energy, feelings of worthlessness or guilt, difficulty thinking, concentrating, and making decisions, or recurrent thoughts of death and suicide. Collectively, you use these symptoms to diagnose a major depressive episode. And if you've had one major depressive episode, you have a higher chance of a second episode, and then a higher chance of a third episode. So what's in neurobiology? Well, again, much like schizophrenia, if you look at the genetics, there's a higher chance here if you have a twin of getting depression, and if your parents have the disorder of you presenting with depression. So here there seems to be even stronger neurobiological links. The first theory also emerged in the 60s, and it's called the monoamine hypothesis of depression. And it originated from the use of a particular drug to treat hypertension. And that drug was reserpine. And what that drug did was it lowered monoamines like noradrenaline and adrenaline. But it was found that a number of those persons being treated with those drugs developed a depressed mood, and therefore people began to wonder if the reason depression occurred was because of low levels of these monoamines. And this led to the development of two types of drugs designed to increase monoamines. There were monoamine oxidase inhibitors. So monoamine oxidase is the enzyme that breaks down monoamines and is part of synaptic transmission. So if you have an inhibitor, that means the neurotransmitter cannot be broken down, and that leads to more of it at the synapse. And the other thing that was developed were tricyclic antidepressants, which block the reuptake of the neurotransmitter from the synapse, again increasing the amount of neurotransmitter. And when these drugs were used, there was some success. About 30 to 40% of people did develop improvement. But just like with schizophrenia, there were some challenges. One, the response was also slow, meaning you give the drug today, but the improvement doesn't occur till 3-4 weeks later. In healthy individuals, if you deplete monoamines, they don't necessarily get depression. And there's variability between patients on the amount of improvement, with some patients not getting any improvement from these disorders. And then in studies, some patients have high levels of monoamines and not low levels. So just like the dopamine hypothesis, we now realize that the monoamine hypothesis has been insufficient to explain what's going on in depression. These are further studies that have shown that what actually happens when you treat somebody with a drug that's designed to boost the monoamines is not so much maybe noradrenaline changes, but is actually changes in serotonin. And now serotonin is being considered the major neurotransmitter where there's a problem in depression. That's why we have the term an SSRI, which stands for selective serotonin reuptake inhibitor. And an example of that drug is Prozac. So what's another theory that might help explain depression? Well, persons with Cushing syndrome, that's where there's too much glucocorticoids being produced, too much of the hormones that are produced by the adrenals are being produced. And one of those hormones is cortisol. And cortisol, as we know, is the stress hormone, one of the hormones related to stress. These persons are very prone to depression. And based upon that, studies were done, as you can see in the graph, where they looked at serum cortisol levels. And they found that people with depression tended to have higher levels of serum cortisol. And so people began to wonder, what is the problem in depression? Derangement, something has gone wrong with the stress axis, the HPA axis, the hypothalamic pituitary axis. And work has been shown that there's increased CRF in the cerebrospinal fluid of persons with depression. There's a decrease of CRF receptor density in persons who have committed suicide. Persons with depression can have enlarged pituitary and enlarged adrenal glands and increased levels of cortisol, as I just mentioned to you. All of these are findings that are not found in all patients, but it does suggest that in many cases, something has gone wrong with the HPA axis, and the stress response is not working properly. Other studies have shown that if you give a drug called dexamethasone, which is designed to suppress cortisol short term, that in persons with depression, it doesn't work. And again, this shows that the system, the axis is not working properly. So this has led to the stress-diathesis hypothesis, which is similar to schizophrenia, that persons with depression have an underlying genetic vulnerability. And then if they experience stress, they become a lot more prone to depression, actually develop depression. And here's one study that looked at a particular serotonin gene, the 5-HTT promoter gene. And they've shown that the increase is much greater with people with 1 or 2 copies of the short allele than those who have the long allele. So if you have the 2LL, the long alleles, and you experience stressful life events, there's a small increase in experiencing depression. But if you have the other copies, and in particular the SS allele, as can be seen here with the purple graph, your chances of experiencing depression after 3 stressful life events and 4 goes up much higher, and your chances of attempting suicide also goes much higher. And the combination of the SL puts you somewhere in between. So this is good evidence of a genetic vulnerability being acted on by stress, then predisposes to depression and leads to depression. And this is called the STRESS-DIATHESIS model. The diathesis is the underlying issues that starts with the genes, abnormal brain structures and functioning, which makes you vulnerable. And then particular stresses act upon that, leading to the psychological disorders. Now let me just conclude by mentioning one important factor in the brain, brain-derived neurotrophic factor. You can think of that as fertilizer for the brain. BDNF causes the neurons to grow and causes them to branch and causes them to be very healthy. And it has been shown that in depression, there are lower levels of BDNF. And stress also leads to lower levels of BDNF, particularly in the hippocampus. And now they have shown that most treatments for depression, the antidepressants and cognitive behavior therapy, lead to an upregulation of BDNF and a growth and an improvement in the neurons in the hippocampus. And so BDNF is a major molecule that's under investigation to help us understand what's going on in depression. So there you have it. We've looked now at depression, and we've seen that the 2 major models are the monoamine hypothesis and the stress-diathesis hypothesis. And we also looked briefly at BDNF. In looking at schizophrenia and depression, I hope you understand that there's a lot of work that still needs to be going on to understand what's the underlying neurobiology of mental illness. But as I said at the beginning, it's hoped that as we understand these things, we can both come up with early preventative measures as well as treatment measures to help those who are suffering with these conditions.